and outstanding work of AAHCI Regional Ambassador, Dr. Ari Siam. Thank you, Ari, and Dr. Iman Budi. And of course, thank you to Regional Office Manager, Ms. Inda Susanti. AAHCI is sharing resources and best practices around the response to COVID-19. And our regional offices have hosted a number of webinars on everything from research issues to online teaching and faculty development to maintaining a COVID-free hospital and other topics. These sessions are all available online. And if you miss them, Chris or Habiba can provide a link to that. Just a couple of other comments. I'm very pleased to announce that AAHCI still is offering as a member benefit free of charge consultation with AIM program consultants through a new process, AIM Connect. AIM Connect is virtual. It's an expansion of the AIM program and designed in response to the extraordinary challenges of the pandemic. So let Chris or Habiba know if you're interested. We still can sign people up for that. Lastly, I want to mention the excellent submissions from the Southeast Asia region to the AAHC President's Council on Population Health. There were so many outstanding submissions. We decided to hold a special session to feature work in the Southeast Asia region, and that will be held tomorrow. So very nice to see everyone. I look forward to a great meeting, and I'll turn the microphone over to Dr. Ari.
Yes, thank you, Dr. Steve Cantor, President and the CEO of Association of Academic Health Center International. And now I would like to introduce Dr. Agustin Kusumayanti, Master of Science, PhD, as our University Secretary, University of Indonesia. Dr. Agustin was elected and appointed as a Dean of Faculty of Public Health, University of Indonesia, 2013. In 2014, to know, Dr. Agustin Kusumayanti is the member of Indonesia's Health Manpower Council, representing the Indonesian's Public Health Association. She becomes the focal person responsible for development and implementations of registration system for public health expert in Indonesia. In 2016, she was elected as the chairperson of Indonesia's Public Health School Association. She is now in the strategic position to steer the development of public health education in Indonesia, as well as to encourage improvement of the capacity and the quality of public health school in Indonesia. Please welcome Dr. Agustin to deliver your remarks.
Okay, thank you, Professor Ari. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. Honorable Professor Arif Fahrial, the Southeast Asia Regional Ambassador of the Association of Academic Health Centers International. Honorable Dr. Stephen Cantor, the President and CEO of the Associations of Academic Health Centers. Professor Margaret McDonald, Associate Vice Chancellor for Academic and Global Affairs, University of Pittsburgh, USA. Professor Adiba Kamarul Zaman, Dean of the Faculty of Medicine, University of Malaya from Malaysia. Professor John Euli Wong, Senior Vice President, Health Innovation and Translation, National University of Singapore. Honorable members of the AAHCI and AAHCI International, distinguished guests, ladies and gentlemen. First of all, let us praise our God Almighty for His blessings, so that this morning we are all healthy and can gather in this positive, with high positive spirits. It is a great pleasure for me to join the Association of Academic Health Centers International Southeast Asia Regional Meeting 2020 this morning. On behalf of Universitas Indonesia, I would like to deliver our warm-up welcome to all participants of this meeting. Universitas Indonesia, as one of the leading universities in Indonesia, encourages multidisciplinary collaborating research among higher education institutions, both at national and global levels. Facing the global pandemic of COVID-19 that hit almost all parts of the world, the need of collaborative research is even getting higher. In this circumstance, the role of academic health centers within the academic health system becomes more significant. Besides providing quality services to the community, there is a high demand for all academic health centers to discover new procedures, drugs, vaccines, and technologies to enhance the quality of COVID-19 prevention, diagnostics, and treatment. We are also challenged to create a new teaching and learning standards and methods that fit with the new norm resulted by COVID-19 pandemics. Furthermore, the fourth industrial revolution gives us also another opportunity to produce innovations in both health services and health education. In the case of Universitas Indonesia, our academic health system is designed to support academic and research activities of 5 health science faculties. Those are medicine, dentistry, public health, nursing, and pharmacy. This design allows us to work multidisciplinary and train our students to learn and implement interprofessional collaborations. Recently, triggered by the COVID-19 pandemic, our collaboration with other non-health science faculties, such as engineering, science, computer science, and psychology, become stronger and more creative. Collaborations with local governments surrounding our campuses also become more meaningful, much more than ever. Our teaching hospitals and laboratories play significant roles as referral hospital and laboratory for the region. Ladies and gentlemen, I really expect that besides tough condition that we are all currently facing, our network will keep growing. Rely on our own capacity and potency. We can expand our international network within the Association of Academic Health Centers International, which connects academic health centers worldwide. This will benefit us to reap a rich and engaging experiences as well as high-level networking opportunities. As an active member of the association, Universitas Indonesia commits to support implementation of academic health system with global knowledge, which leads to a multidisciplinary research and health practice improvement. I believe that academic health centers, as important part of global and local health system, have significant roles to overcome the COVID-19 pandemic. Considering the need of wider and stronger collaboration, this meeting suits our current situation. During our meeting, we will share updates of integrated healthcare services, latest clinical advancements, progress of research and development projects, as well as current adjustment in health professional education. I hope this regional meeting will benefit all participants, both the members of the association and individual health professionals, with better understanding about academic health center and its important roles during COVID-19 pandemics. Last but not least, I would like to thank Professor Arif Fahri Al-Syam, the Dean of the Faculty of Medicine, Universitas Indonesia, as the Southeast Asia Regional Ambassador of the Association of Academic Health Centers International for the efforts have made in making this meeting possible. Have a truthful meeting and may God bless us always. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Agustin. So, Honorable Dr. Agustin, Honorable Dr. Stephen Cantor, and also our keynote speakers today, Professor Margaret McDonald, Professor Adiba Kamaruzaman, Professor John Wong, also Deans of Faculty of Medicine in Southeast Asia, Deans of Faculty of Medicine in Indonesia. Good morning. As the Regional Ambassador of Association of Academic Health Center International Southeast Asia Regional Office, I would like also to express my warmest welcome to all of you to our 2020 regional meeting with the theme assessing the adaptation and resilience of academic health centers during the COVID-19 pandemic. It is such a wonderful opportunity for us to all meet virtually during this COVID-19 era. I'm delighted to see a diverse representation of participants from many regions. It shows the importance of our meeting at this time and our shared interest in facing the COVID-19 pandemic, with the team assessing the adaptations and resilience of academic health centers during the COVID-19 pandemic. The sessions we have planned serve to provide valuable insight into critical issues and challenges and bring together members of the regions at the critical time to share their different perspectives and experiences. We have individual panelist sessions that will be held today and tomorrow that Dr. Cantor mentioned, covering 5 topics and featuring 21 speakers from other countries and AAHCI member institutions. Each session touched on the role and experience of academic centers in facing political change during pandemic, continuing medical education, population health, and development of treatment and vaccines, and preparing for the future. This regional meeting is the second regional meeting we have held since our appointment as regional office of AAHCI Southeast Asia. And I'm proud to inform you that during the COVID-19 pandemic, we have held several activities related to COVID-19, such as webinars, several roundtable discussions, and successfully published the AAHCI Southeast Asia inaugural newsletter on perspective of COVID-19 impact. I appreciate the contribution from our distinguished members of AAHCI and also AAHCI for sharing their experience. Without a doubt, it has found that the AAHCI is a unique and important organization for us to get the full support and we need in such challenging times. I believe AAHCI is also the right place for academic health centers to benefit from a fantastic network of other peers and leaders worldwide. Their programming and informational services are crucial in advising and applying the latest knowledge and on managing an academic health center. Thank you again for all you participants, ladies and gentlemen, and I hope you all enjoy our regional meeting and can benefit from this event. Okay, I think we can go to the first sessions of our sessions about the mitigating COVID-19 during times of political change. As you know, the COVID-19 pandemic has impacted international relations and affected the political systems of our countries, going as far as the suspension of legislative activities and rescheduling of elections in some cases. In other cases, there has been a disconnect between what governmental agencies tell the public and the recommendations given by the scientific communities. Also in Indonesia, regional elections will be held on 9 December 2020, and the General Elections Commission has prepared a voting protocol, including for those voters who are confirmed positive for COVID-19. To ensure the success and the safety of this event, our government has raised the budget to be to 20.4 trillion rupiahs, or around 1.4 billion US dollar for the implementations of health protocol during the election. Our government said that the regional election must be held under strict health protocols to ensure that they are safe and democratic. And today's session, we will hear the case of America, Singapore, and also Malaysia. Before we begin, I will introduce all the panelists. First, Dr. Margaret McDonald. She is an Associate Vice Chancellor for Academic and Global Affairs, Health Sciences at the University of Pittsburgh, and Associate Professor of Epidemiology in Graduate School of Public Health, and an associate professor of psychiatry in the School of Medicine and a core faculty members of its Center for Global Health. In the capacity of Vice Chancellor, she coordinates the development and support of research, educational and public affairs initiative within the health sciences school and between the health sciences and other university units, provide expert support to university executive staff, and promotes and implements health-related collaborative relationship with academic institutions in other countries. The second keynote speech, Professor Adiba Kamaruzaman, trained as infectious disease physician and is presently the Dean of Faculty of Medicine, University of Malaya, and adjunct associate professor at Yale University. Professor Adiba has played a leading role in the response to HIV epidemic in Malaysia and globally, especially in the area of HIV prevention for people who use drugs. She is currently the president of International AIDS Society and a member of UN AIDS Advisory Group. Her achievements have been recognized through several national and international awards, including honorary doctor of laws from her alma mater, Monash University, for her contributions to medicine and as health advocate. The third speaker, Professor John Wong, we know him very well here in Indonesia, is a Sabel Chen Professor in Medical Sciences, Senior Vice President, Health Innovation and Translations at the National University of Singapore, and Senior Advisor of National University Health System. He is a medical oncologist, hematologist by specialty, and a member of US National Academy of Medicine, co-chairing their commissions and creating a global roadmap for healthy long life. Okay, for each panelist will be given 10 minutes to speak, and after all the panelists have finished, there will be Q&A sessions. For participants, you can type your question at the QA feature at the bottom of the Zoom toolbar on your screen, and we will deliver your question to the panelists. Please, Professor Margaret McDonald, your time.
Thank you for the invitation to talk about how COVID-19 has affected the United States and especially US medical education. More than half the world's countries are mandating the use of face masks while in public spaces. Unfortunately, my own country is not one of them. The first two countries to issue a nationwide mask mandate were Vietnam and the Czech Republic. As you know, a person wearing a mask is less likely to be infected with the virus. An infected person wearing a mask less likely to transmit it. And when both parties are wearing masks, the level of transmission risk dramatically decreases. Our country has also been led by a science denier. Donald Trump's presidency has been marked by a dismissal of science and evidence. The US experienced a failure of leadership, leaving states to fend for themselves as the world watched. States competed with one another to purchase supplies of PPE, ventilators, and other supplies needed to combat the virus. At the same time, the Trump administration ordered hospitals to bypass the highly respected Centers for Disease Control and Prevention and to send all COVID-19 patient information to a central database at the Department of Health and Human Services. The move alarmed health experts who feared that the data would be politicized or withheld from the public. And the states were left on their own. While most now have a mask mandate, there is no consistent national approach. As one public health official said, reopening some states is like having a peeing section in the swimming pool. And then we had an election. Well, sort of, we're waiting. But finally, we think we can begin to breathe a sigh of relief that the US will return to fact-based responses to public health crises. One of President-elect Biden's first actions was to name a 13-member COVID-19 task force, which has been described as a who's who of former government health officials, academics, and major medical figures. That list includes Dr. Rick Bright, the former head of the Vaccine Development Agency, BARDA, who was fired by Trump in April. In my own state, we've been fortunate. Our governor implemented science-based policies from the outset. And in our own county, Dr. Deborah Bogan, director of our health department, is a former Pitt Med faculty member. In fact, she left the university for the new position only a couple of weeks before the pandemic broke. So what are we doing at our own university? At Pitt, we recognized early that while decision-making needed to be decentralized, it also needed to be well coordinated with a chain of command that was almost military in its organization and reporting structure. Two entities were deemed essential. The Healthcare Advisory Group establishes standards and guidelines for campus operations and monitors and revises those guidelines in response to the changing pandemic. The COVID-19 Medical Response Office is our boots on the ground, responsible for testing, contact tracing, quarantine, and isolation protocols. As our chancellor said, it's a public health department at Pitt. The Healthcare Advisory Group evaluates the university's operational posture weekly and makes a recommendation about whether to leave it as it is or to change it. We have three postures: high, which is the most extreme, elevated, and guarded, similar to the red, yellow, and green of a stoplight. All of these posture decisions are based on public health data from the national CDC level to the very local level, including information from our clinical partner, UPMC, on the number and severity of cases, ICU and other bed capacity, and other parameters. We've also created a public-facing at-a-glance dashboard to see where we stand on campus and to assure transparency of information to students and their parents. Most US universities have developed something similar. And if you look up at the top right, you can see that our caseload happens to be rising right now. It hasn't been easy. We've had to maintain a fine balance to have enough mitigation to keep campus virus levels low, but not so much that the students stop complying. We've had to have enough containment to control outbreaks, but not so much that students think they're virus-free. And we've had to have enough communication that students and their parents are informed, but not so much that they stop paying attention to what we're sending them. So where are we now? Actually, we're kind of where we predicted we'd be. In Allegheny County, our cases are up, but our death rates are down. And that's exactly the scenario for which we had been planning. And we think there are two reasons for this pattern. One is that therapies for COVID-19 have improved, including treatments like the steroid dexamethasone, as well as adaptive trials that we're conducting here at Pitt and UPMC. But the second reason is the widespread acceptance and wearing of face masks. But what about medical education? And after all, that's the topic we're really interested in tonight. So let's start at the national level on that. All of you are very familiar with the Association of American Medical Colleges, as well as the Liaison Committee on Medical Education. While AAHCI represents all US and Canadian medical schools and affiliated hospitals, it really has no formal regulatory role. However, it does wield great moral authority. LCME establishes eligibility for students to take the US medical licensing exam and enter the ACGME residency training programs. In short, medical students' futures depend on LCME accreditation. Early in the pandemic, AAMC guidance called for a full halt to medical student participation in direct patient contact. However, by April, as we gained more knowledge about COVID-19 and as testing and PPE became more widely available, students were allowed to resume clinical participation, provided, however, that community spread was low, that reasonable safeguards were in place, and that the clinical experiences met the school's educational program objectives. However, students could not care for patients with confirmed or suspected COVID-19. Most US medical schools did indeed suspend all face-to-face educational activities, at least early in the pandemic. However, as they resumed, most of those schools were also able to go to graduation on time. And I couldn't resist showing you a shot of some of our students singing the national anthem at our own virtual graduation. By August, national guidance had evolved further. Basically, AAMC said that although medical students are not essential healthcare workers, taking care of patients, even in such challenging circumstances, is exactly the skill they signed up to learn. So students could now take care of COVID positive patients, but unless clinical engagement was a mandatory part of the curriculum, student participation in other clinical activities had to be entirely voluntary. Concurrently, LCME recognized that schools might need to make a number of adjustments due to the pandemic, and the agency agreed to a flexible approach, including shortening some clinical experiences, as long as the duration of medical school remained at least 130 weeks. But then there's the US medical licensing exam. As you know, the exams are given in 3 parts, and most states require all 3 for licensure. However, USMLE testing centers closed in March. Scheduled exam dates changed, and the centers opened sporadically when they opened at all. Students were confronted with a real dilemma. While most medical schools in the United States give students 6 to 8 weeks of time to prepare for the exam, the students had no idea when they could take the exam. In fact, step 2, clinical skills, is still on hold. As if that wasn't enough, and to summarize, there has been no national coordination at the US level. In our own state, in March, as I mentioned, the Department of Education required medical and other health sciences schools to remove students from clinical settings. And in later months, there was confusion between 2 departments at the state level, the Department of Education and the Department of Health, about who even had jurisdiction over medical schools. Finally, at the end of May, our governor gave the okay for clinical training to resume now. And here we are, getting ready for the US Thanksgiving holiday. I think that's 10 minutes, and I'm happy to answer questions.
Okay. Okay, thank you, Margaret. I think this is important message from you to know about the situation in America and also how to solve the problems of there. So next speakers, Professor Adiba. I have mentioned about her before, and okay, please, now time is yours, Professor Adiba.
Thank you very much, Dinari, and good morning, everyone. Listening to Professor McDonald, I think most of us in medical education have experienced similar ups and downs and and the uncertainties of when it is safe to bring our students back into the clinical component of their education. So it's kind of reassuring to hear of the similar actions that we have taken to ensure that our students have enough training whilst maintaining their safety. Now I'm going to pivot to something a little bit more, a little different to medical education, a topic that's close to our hearts, but Dinari had asked me to speak about our role as public health and clinical practitioners during COVID-19 and in periods of political change. Professor McDonald, alluded to some of the difficulties in the US, and I think the one thing about COVID, and I guess most pandemics in general, is that politics and health and public health are inextricably linked, and the success or otherwise of a pandemic response lies not just in the know-how of the medical community, but of course, also in political will and political directions and trust that the public have in the politics and in us healthcare workers. Now, in terms of the complexity of ensuring that democracy continues because of the high transmissibility of the SARS-CoV-2 virus, it has created enormous problems for governments and democracies around the world. Because health and safety concerns remain as the dominant factor in deciding whether or not to have elections. Now, I just heard from Dinari, we all just heard from Dinari this morning that Indonesia, an enormous country with tens of hundreds of millions of people, are facing an election, and this is not going to be an easy task, I'm sure. 50 countries around the world have gone ahead to hold elections during the pandemic. 9 of them were in Asia. Some countries have elected to postpone, and some marched on with the pandemic. As you saw, the large one just recently concluded in the US. Sri Lanka held theirs after an earlier postponement on August 5th, and Hong Kong has postponed theirs. New Zealand and Singapore and New Zealand also, after initial postponement, safely carried out their elections. Now, what are the impacts? So the 3 major constraints to elections, of course, restrictions on freedom of movement and assembly, in particular in safely carrying out campaigns. And then when it comes to the actual voting day as well, then the concerns around health-related risk for voters and officials, and all these things can lead to operational complications and delays, as again we saw with the US elections that took more than a week to conclude. However, there are ways and means of ensuring that elections continue safely, and these are just some examples. It's by no means a complete list, but I think many countries around the world have adopted some of these alternatives and interventions to ensure that campaigning continues, voting continues, and even the ability for citizens to vote in person. I think Singapore did very well in terms of continuing campaigning via the internet and through the social media. I'm not sure about the US because I wasn't following the campaign apart from what you see on CNN, but I'm sure there was a lot of that. But there was also, I think in the US, we're aware of large rallies continued, and I guess perhaps to the detriment of the control of the pandemic. And then when it comes to voting, there are, of course, alternative remote voting methods by post or online through a computer or mobile phone that can be secured. However, for lower or middle income countries, this the cost of having this kind of digital voting or even postal voting might just be too prohibitive. And finally, if we are voting in person, there are many steps that can be taken to ensure safety. Of course, this leads to long queues and delays. The principle of which is to reduce crowd size, to ensure good ventilation, and to ensure safety. Some countries, took the steps, for instance, to limit the time, and started with the elderly who are more at risk, making sure that voters brought their own pens and attention to all these details that can increase or reduce the risk of transmission at these polling centers. Now, I just want to share how these 4 countries that went ahead with the elections fared. So Singapore, South Korea, New Zealand in Asia, and Malaysia, although it wasn't a general election, we had a big election in Sabah that unfortunately led to a third wave, as we call it here in Malaysia, after a relatively good control of the pandemic since it first started back in January, February in Malaysia. So as you can see, Singapore, with a population of 5.6 million people, had a national election in July, and at the time, or on the day of the election, had about close to 200 daily cases, and a month after the election actually saw a slight decrease in the number of daily infections. Professor John Wong is here on the panel as well. I'm sure he can add further details to this. For the most part, I think in Singapore, the transmission was within the foreign workers community and was not so much in the general community. And with that, I think they went through and safely conducted an election. South Korea, as we all know, of course, has been one of the countries globally that has successfully controlled the pandemic, and had very few daily cases when they went into the election, and again had actually saw a drop in the number of daily cases post-election. And similarly, New Zealand, which if anything, is probably going to be the first country that's going to totally eliminate, or they have in a way declared total elimination of COVID-19 once again, after a delay, conducted their elections very safely, and went from 3 cases on the election day to just 1. So I guess the moral of the story is it's safe to conduct an election, provided there is low-level transmission and attention to all those details that I shared with earlier. Now, unfortunately, there is also an example of how not to conduct an election, and that unfortunately came from my own country. And this wasn't a national election, it was a state election, albeit a very large state in Borneo, Sabah, with a population of 3.54 million, so not too far from New Zealand. And it was a general state election that was conducted on the 26th of September. At the time, the state was seeing an average of about 80 cases, and I'll show you this in a graph later on, where in Borneo there are a lot of undocumented migrants, and some of a large proportion of the infections were occurring amongst undocumented migrants, and unlike in Peninsular Malaysia, where we were not having a good control of that community, this low-level silent community transmission. And unfortunately, as a result of not adhering to masking rules and social distancing rules, and most importantly, of not having large gatherings in closed settings, we had an enormous upsurge in the number of new cases post-election in Sabah, as you can see there. So this was what happened. Just moving this a little bit. So the election. This is the national sort of EPID curve in Malaysia. We first heard about the outbreak in Wuhan here in January, and just as with many countries in the region, took very early proactive measures to ensure that we didn't have an outbreak here in Malaysia. So pretty much soon after initial imported cases from China, the borders were closed, and extensive and intensive contact tracing, testing, contact tracing, and isolation and quarantine were conducted. And we were doing extremely well in the initial part of the epidemic, similar to Singapore and many other countries in the region. Unfortunately, in early March or mid-March, there was a large religious mass gathering, which led to an outbreak here that took a while to come under control, but came under control, it did, and this was what we call the first wave. And for many months, things were quiet in a sense, with very low level of transmission, until the second wave that occurred, which was also quite well controlled, and led to many months of very few cases, with really double-digit new cases daily for a good 6 months or so, until the fateful elections in Sabah. At the time, as I mentioned, there were already 80 or so daily cases in Sabah. The elections continued on the 26th of September, but before that, there were all this campaigning that was taking place, where strict adherence to distancing and masking, I guess, were not complied to. And we then saw this massive increase that is still not coming under good control in Sabah, with daily cases of between 200 to 300, intermixed with the porous borders that we have, with continued community transmission from different clusters. On top of that, there was some delay in instituting border closure between states, although there was this rapid rise in cases in Sabah. Those who were coming back to Peninsular Malaysia were allowed to come back, and unfortunately strict quarantine, as we expect from those coming from foreign countries for 14 days, didn't apply to domestic travel, and that resulted in transmission of cases now in Peninsular Malaysia, and now we're faced with sort of moderate level transmission in Malaysia, with various clusters that can be traced back originally to people coming back from Sabah, and now we also have outbreaks with foreign workers and prisons as separate or clusters. So we here in Malaysia, we're now grappling with multiple clusters from dormitories and also from detention centers and prisons, and trying to gain control of the original transmission from Sabah. So this is a larger graph. As you can see, we had that first wave that was reasonably well controlled for many months, and then here was where the elections took place, and we now have this massive third wave or surge that needs to come under control. So this is an example of how during a political transmission, if those basic requirements of public health interventions such as masking, physical distancing, and ensuring that there's no mass gathering do not take place, how you can get a relatively well-controlled epidemic very quickly, coming undone. And it's going to take some time, I think, to bring this back to where we were back in June, July, and August. So this is a picture that even our PM concedes that Sabah State Poll may have been reasons behind a recent spike. As you can see here, although there was, many people were wearing masks, but certainly this is not what we would call adequate social distancing. And in terms of limits of gathering, this is definitely more than 50 people in this room here. This was during the Sabah campaigning and elections. So, that basically brings me to the end of my talk, and to emphasize how, the difficulties in balancing, like what Dr. McDonald had just said, in balancing the need to ensure that essentials of democracy continue versus making sure that the public health principles are maintained, so that we don't run into the problem that we just have had in Sabah, and now to some extent nationally. Now, I can't help myself. I'm going to end my talk by, there was quite a lot of discussion in the media about, examples of countries that have done well, and coincidentally, many are led by women. And whether you subscribe to this or not, there were two researchers from the US, I think, that actually tried to look into this, and although the scientific findings was that yes, there was there really was something in it about women leaders and better management of the pandemic from countries in the East to examples in Europe. I think there are many also who remain skeptic about it. So with that, thank you very much for your attention.
Yes, thank you, Professor Adiba. Yeah, I agree with you that the best from your information about Sabah elections, I think the situation similar here in Indonesia, that the problem start when the crowded, when we cannot prevent the crowd, so the increased number of COVID-19 cases. And also the inspiring last slide to talk that maybe this is good information for Indonesian people. Please choose the woman for governor or mayor for the next elections. Okay, thank you, Professor Adiba. Next, Professor John Wong. I have give brief CV him before. Please, Professor John Wong.
Well, thank you very much, Dean Ari Faryalsyam, and thank you to the University of Indonesia and to Dr. Stephen Cantor, the President and CEO of AAHCI, for inviting me to share my comments. I'd just like to start off by saying that Dean Adiba certainly has my vote. I'm going to take a slightly different tack and perhaps share with you what we did as an academic health system in Singapore, and perhaps share some of the some of the value of academic health systems at the time, of a national crisis such as a pandemic. So Singapore's experience, Singapore's experience has been heavily influenced by what we experienced in 2003. Singapore has been investing in pandemic preparedness, I would say, for the longest of times, but we certainly stepped this up after 2003, after SARS. And that included ensuring that there was sufficient personal protective equipment stockpiled, equipment, as well as drugs. We increased the number of isolation rooms in all healthcare facilities. And we built a purpose-built National Center for Infectious Diseases, which serendipitously, or very fortunately, was completed at the end of last year. We have been investing significantly in strengthening contact tracing capabilities. Infectious disease legislation was updated, and we've been having regular drills. When China alerted the world on December 31st of 2019, the first thing that happened was that Singapore formed a multi-ministry task force. And this is really important because in dealing with an infectious disease outbreak, it really requires a whole of society and whole of government effort. It's not just a healthcare issue. And I think that we've all, experienced this, the effects on the economy, of the need for communication. And in Singapore, we had a substantial outbreak amongst our guest workers. So this really involved the Ministry of Manpower. Singapore enforced strict border controls, and we developed our own RT-PCR diagnostic kit after China shared the sequence of SARS-CoV-2. And our Department of Laboratory Medicine ensured that the turnaround time from test to result given back to the patient was within 24 hours. We've been ramping up our capacity significantly. When the first wave hit, we were able to do just under 3,000 tests a day. We're now able to do 20,000 tests a day, and we have the capacity to go up to 40,000 tests a day. Singapore has swabbed about 15% of its population, and it now has, because the guest workers are at a high risk, we have a rostered swabbing of all the guest workers. We swab regularly all high-risk facilities, such as nursing homes. And in Singapore, anyone with respiratory tract symptoms essentially can get a swab, and a swab at our public healthcare facilities is essentially provided free. Importantly, all suspected cases and definitely all confirmed cases are isolated immediately. And there's very aggressive contact tracing and quarantine of all contacts. The contact tracing team was ramped up when the first wave hit. We had, at any one time, we have 3 contact teams essentially ready to go. And this has been ramped up to 50, led by the Ministry of Health, but with significant assistance from the police and the Singapore Armed Forces. and enhanced by technology. So everyone's encouraged to download an app on their iPhones. And for those people who aren't used to using iPhones, especially the older population, are given a token. We ensured hospital capacity by delaying elective admissions and procedures. Thankfully, our healthcare system has not been overwhelmed with patients. At the height of the first wave, we had 150 vacant ICU beds, with the ability to bring on an additional 300 with 450 in reserve. We've tripled the number of isolation rooms in all public hospitals. And we built these community care facilities, which could house a significant thousands of people to be able to isolate and monitor people who were infectious, patients who were infectious, but did not require hospitalization. Because as we know, we had a significant number of asymptomatic patients. So in terms of our approach at the academic health system, and this is reflected in, I would probably say in all the public healthcare facilities in Singapore, three strategic pillars. So the first is our academic health system operates primary care, general hospitals, tertiary hospital, national centers, as well as the medical, dental, nursing, and public health schools. So the first strategic pillar was collaboration, this whole concept of one national university health system, working across primary to tertiary care, and harnessing the health science schools so that we really had this enormous brain trust and collective talent. So collaboration across our whole health system, which is entirely integrated using one electronic health record and one governance. The second was to really calibrate so that we were able to constantly refine our plans because dealing with a totally new infection while we were still trying to understand modes of transmission, the ability to be really agile was very important. And then thirdly, really the importance of leadership, clear and decisive leadership at every level. So it's not just at the political level, but it's leadership at the ministries, at the very apex of our health system, down to heads of department, and down to each of the wards and clinics. So this was really important. And we operated across 8 functions. Firstly, human resource, really making sure that our staff were really trained in PPE use, deployment of staff, so to make sure that people didn't get burnt out, and a very strong attention to welfare. Our fever tents, we brought in the ability to cool the tents, and now the tents are air conditioned. So because working in PPE in the tropics is really quite demanding. Having very good intelligence, and this is where I think organizations like AAHCI are really sharing information globally and really understanding what was happening first in China, and then hearing what was happening in Europe, and then the United States was very, very important, and really sharing what worked and what didn't work. Third was operations, very important. So besides the leadership issues and the command structures that I mentioned, really making sure that our laboratory medicine teams were beefed up, and because the ability to handle huge volumes of tests, 24 hours a day, 7 days a week, and with really no room for error. Again, we're very grateful to our colleagues in laboratory medicine. And of course, all our colleagues in infectious disease and epidemiology. In terms of logistics, very important to make sure that we monitored and made sure that we had sufficient equipment and that this was constantly available. We went through our plans constantly to make sure that we did our scenarios and there was advanced readiness. Communications was important so that we could ensure that staff were provided with timely, concise, and practical information. Then a big push for digital, for telemedicine. I think we saw this, we communicated a lot with our patients through telemedicine. And I'll talk briefly about what we did in research, and then working with all our stakeholders. So in terms of education, there was strict adherence to both university as well as healthcare institution rules and protocols. We reduced our student numbers in the hospital at any one time to allow better supervision. What we did was that for students who weren't in the hospitals, they were in the medical school doing simulation training as well as on model patients. The clinical postings continued. All our clinical postings continued. There was a time that we suspended clinical postings in anesthesia, dermatology, and infectious diseases, mainly because of the infection risk. But we have subsequently resumed all except our infectious disease clinical posting. But during the clinical posting, really focused on learning outcomes that required patient contact. And as mentioned, we complemented our clinical training with a lot of simulation-based learning. We have we're very proud of our simulated hospital. We have a 50,000 square foot simulated hospital, which can simulate everything from pediatrics to OBGYN to operating rooms and ICUs. And then, of course, all our assessments continued, but modified to ensure that safety measures were in place. So I just want to switch briefly and share what we did in terms of harnessing the academic enterprise. And I'll give you perhaps two examples. The first example was when we ramped up our swabbing and testing capacity. We realized that if we were really going to swab at the volumes that potentially we could do 40,000 swabs a day, up from 3,000, that there was a danger that we may run out of swabs because the whole world was essentially buying swabs, and we're always very conscious of supply chain problems. So we got together with our School of Engineering as well as our School of Design. So there's engineers, design experts, working very closely with our ENT and infectious disease departments in designing our own nasopharyngeal swabs, first using 3D printing because that's fast. Now we've switched to injection molded. And we did our clinical trials of our, essentially the university-made nasopharyngeal swabs. We did the clinical trials with the commercial brands, both at the National University Hospital and at the Singapore General Hospital, to demonstrate that they were comparable in terms of producing CT counts for RT-PCR. And of course, safety, comfort, and efficacy. And so this has really helped our ability to continue containing the epidemic. The other group, our anesthesiologists, work again very closely with engineering and design to be able to produce a droplet and aerosol reducing tent, which was collapsible and portable, which could be put up in literally in less than a minute to allow staff to safely intubate patients with much greatly contained aerosol production. And then finally, in terms of what we're working on now, I think that there's a big push to develop rapid, specific, sensitive, safe, easy to use, as well as affordable point of care tests. We set up this criteria to our engineers. Our engineering school, working very closely with the medical school, as well as the infectious disease colleagues, have been developing, and we've got 3 prototypes in development, and we hope to have these released and commercialized soon. We're also developing the ability to do saliva-based tests because that's much less invasive, and developing a safe way to collect saliva with a funnel so that one doesn't contaminate everyone around you when you're trying to produce essentially pharyngeal phlegm. And then lastly, our immunologists have been working very closely in isolating, cloning, and characterizing monoclonal antibodies, both for therapeutics as well as antigen detection tests. And these are completing their clinical trials. So I think that this has been our efforts in really demonstrating the value of an academic health system in helping a country deal with a brand new disease. And I think that it's through organizations like the AAHCI that we are able to share our knowledge and our experience and really make sure that we help our countries see ourselves through these challenging times, because unfortunately, this will not be the last pandemic, and we will certainly have, unfortunately, a few more in our lifetime. Thank you very much.
Okay, thank you, Professor John Wong, to tell us about the rapid response of your government to increase number of tests, and also to hospital prepare for patients, and also the ICU. And also some innovation from NUS. I think this is good for information for us as well. Okay, so next, yes, for participants, I think you can write your question to Q&A and also chat from the Zoom. But anyway, so I think we have one question here about the vaccine. You know that the vaccine will come, and maybe every panelist can comment that if you have your government, or maybe you have any suggestion how to the policy when the vaccine come, mean that the programs of vaccinations. So here in Indonesia, we have still discussed about that the people must pay, or this is a government cover everything for vaccine, and also who people to be prioritized first to get vaccine. So maybe any comment from panelists about the vaccine. First, Professor McDonald first.
Okay, it is my understanding, although we are not certain, because going back to Professor Adiba's political comments, the administration in office now, the Trump administration, has not conceded the election and is not sharing information about vaccine distribution planning that is going on under the Trump administration with the incoming Biden administration. So in the US, some of those plans are very much up in the air. However, President-elect Biden has assembled a team and is seeking input from other public health professionals, not necessarily members of the Trump administration. It's my understanding that when Biden is in office, he hopes to distribute the first available vaccines, which are likely to be the Moderna and Pfizer vaccines, probably first to frontline healthcare workers, then probably other essential personnel, populations at risk as the first priorities. which vaccine? Honestly, whatever is available in different areas of the country. The Moderna vaccine can be kept with regular refrigeration, so will be logistically easier to handle than the Pfizer vaccine. But meanwhile, other vaccines are in the pipeline. So that's where we are, I think. I'd love to hear about the circumstances in other places.
Okay, thank you, Professor McDonald. Maybe from Professor Adiba, have any?
By the way, I loved your last slide.
Yes, thank you.
But you might. Okay, so in a way, Dean Ari, Malaysia is, I think, still at the stage with similar to Indonesia. There's lots of discussions around how to procure, how to distribute the vaccines, who to give to, who pays and who doesn't pay. We, I believe, have signed on to the COVAX consortium, but there have also been reports of participation with the Sinopharm and Sinovac vaccines. But when it comes to rolling out, let's say, through the COVAX consortium, if we, we're in the queue for that, then, like most other countries, I think the priorities will be to healthcare workers and those at risk. The problem, I think, is, like in the US and in Europe, you've got a sizable population of those at risk in terms of by age. In Malaysia, well, we've got a comparably younger population. But on the other hand, we have a large percentage of the population with non-communicable diseases such as diabetes and obesity, which puts them in the at high risk category. So, deciding which at risk category should be prioritized is going to pose quite an ethical challenge, I think. And also in terms of payment, these vaccines are not going to come cheap if we're going to try and achieve, say, 50% coverage or 60% coverage. And even if it's at $10 US, by the time you add transport, the cold chain and everything else, it's all going to add up. So whether, I'm not privy to this, whether the government is going to make it, free like we do for national vaccination programs for childhood vaccination, for instance, and HPV vaccine for young adolescents. But, others will have to co-pay. Those who, what we call the B40s, those who are in the lower socioeconomic group, I would imagine will get the vaccine free. But those who can afford may have to co-pay. I don't know that. So I think these are discussions that are still underway.
Okay, thank you.
I need to add one thing because I think it's important, and that's that there remains a great deal of vaccine hesitancy.
Yes.
In the US, I mean, it's not the vaccine that will protect us, it's the vaccination that will protect. And especially in our Black and Latinx communities, there's a high level of distrust about even this new vaccine. So that's a huge issue that we'll have to face when the vaccines become available, is getting the populations to actually take the vaccine. And there's also been higher incidence of disease in those populations, in part because they are many of them are in those essential worker categories.
Yes.
Yeah, it is indeed. There's quite a movement here too in terms of the anti-vaccine movement that we will need to counter.
Yeah, so I think this is the global issue, not only in our regions but also in America as well. So maybe Professor John Wong have any Yeah, do you have any programs from your government about the vaccination?
Yes. Singapore has been following this very closely. We are signed up to the WHO Pact. We've been tracking. So firstly, Singapore has been developing one of the vaccines, an mRNA vaccine. Duke NUS, our sister medical school, as part of the NUS system, has been working with Artis Pharmaceuticals. And the trial is essentially is in phase 3 now. Certainly Singapore will be purchasing vaccines from the major pharmaceutical companies, as well as developing its own. We've established a blue ribbon panel chaired by my colleague, Professor Benjamin Ong. He was the immediate past Director of Medical Services and is comprising infectious disease experts, immunologists, as well as public health experts to come up with the criteria of how, essentially who should be vaccinated first and how it will be rolled out. Thankfully, in Singapore, there's still a pretty high level of trust in that the Ministry of Health will do the right thing. And so while we are watching the anti-vaccine movement, we've been watching it very closely for I guess for a long time. We hope that it will not be a significant feature in Singapore. But Singapore is such an open city-state, and for us, it's really important that essentially the whole world be vaccinated, because it really should be no one left behind. Currently Singapore has had 0 cases in the community or in the guest worker dormitories, and essentially every day the new cases are all cases of people entering Singapore from other countries, and it's been detected while they were in quarantine, in that 14-day quarantine. So I think in terms of restarting the economy, I think we do really need to see how we can help how we can help the world achieve the vaccination. As Dr. McDonald said, it's going to be the actual vaccination which is critical.
Okay, thank you. This is one question from participants, Dr. Neni, to you, Professor John Wong. Yeah, how to collaborate across primary to tertiary care? Who is the lead of these coordinations? I mean, what are the role of National University Hospital System? Because you mentioned about the primary and tertiary. Okay,
yes.
Please.
So the way we have organized the National University Health System, we have in terms of clinical care, we have essentially we have one group chief, one group chairman of the medical board. So there's we have one person who is responsible for coordinating all clinical care across all our institutions. So currently it's Professor Emmerich Lim. He is a hand surgeon, and he is responsible for setting the standards and getting the heads of the primary care clinics, the hospitals, the general hospitals and the tertiary hospital and national centers, all agreeing to a common protocol, all agreeing to certain standards, and really trying to make sure that we keep track of what's happening, which places are perhaps having more cases, so we can do load balancing across our institutions, making sure that if there are issues with equipment, or if there are issues whereby people are being quarantined because they were exposed. You want to make sure that you send reinforcements to, to keep, to keep the system running. Now, when we had the outbreaks in our migrant worker dormitories, the staff that were sent there, essentially we had volunteers from across all our institutions volunteering to go and manage the outbreaks in the migrant worker dormitories. And again, when so we had because we reduced all our elective surgeries, our surgical colleagues essentially all volunteered to go and help man the facilities in the dormitories. But then again, making sure that we were able to distribute our workload evenly. So I think it was very important to have one person given the authority to be able to set the standard and ensure that protocols were followed, and got the intelligence and was able to plug into those 8 operational domains that that I shared. So for us, it was the way we've organized the National University Health System is that we have got one group chairman medical board, and then we've got one group chief of medicine, one group chief of surgery, one group chief of family medicine. So we, we do really see ourselves whereby each institution, whether you're a primary care clinic, a general hospital, a tertiary hospital, everyone knows their role that they have to play in chronic disease management as well as in emergencies. Over.
Okay, thank you, Professor John Wong. I think this is the question for Professor Adiba and Professor McDonald about from Dr. Haryo. What is the best strategy for communicating and advocating evidence-based health intervention to a leader that is more economic oriented? Like in America or maybe in Malaysia. Please, do you have any suggestion for that, Professor Adiba?
Yeah. So I guess it's right from the beginning of the epidemic. It's not lives versus livelihoods was the principle that we all want to adhere to. It's not sort of pitting ones against the other. It's making sure that you take care of both. Yes, it's easier said than done, but you're not going to be able to open up the economy if you don't have good control of the pandemic. I think it's become very clear, and so those are the kinds of messages that we need to keep reminding our political leaders, that if you rush to kind of ease the restrictions, I suppose, then you are going to jeopardize the public health gains. Having said that, I think compared to February, March, we have learned so much more in terms of how to contain the pandemic, and perhaps we don't need to be so quick to resorting to lockdowns as was the case back in February, March, because we weren't so sure what was going to work best and what wasn't. I think we know that the virus is extremely easily transmissible, but having said that, we also know what we can do to minimize the risk of transmission. And so, things like masking and physical distancing are here to stay. But at the same time, Singapore, Indonesia, Malaysia also have that comparative advantage of the climate and, sunshine and humidity and heat has been shown to reduce the transmission. So all this new knowledge, I think, needs to be transmitted to our leaders so that we can adjust the kinds of restrictions. I think we need to tell our leaders, pay more attention to things like ventilation, and this might allow restaurants, particularly in our part of the world where outdoor dining is so possible, all those things that we can do to ensure that, as much of businesses and economy, etc., can continue, versus ensuring that we keep a lid on the pandemic, because having swaths of the population locked down is also not going to do anyone any good, whether it's financially or also when it comes to mental health. So I think lockdowns should be a mode of last resort when there's very, very high community transmission, but we must do everything we can, particularly keeping schools open, given the knowledge that we now know about the virus.
Okay, yes, please.
When the leader is a science denier, I'm not sure there is anything to do that can convince that leader to change his mind. I don't know how many of you might have been watching Mr. Trump after he returned to the White House from Walter Reed Medical Hospital after having had COVID-19. The first thing he did when he walked up to the White House balcony was to remove his mask. So our only hope in such a situation is that some of our population might be listening to the scientists themselves, like Dr. Anthony Fauci, who's actually become a cult figure in our country during the pandemic, and follow some of that advice. The incoming administration, the approach that's being taken by the new leader, the Biden-Harris team, is that in order to get the economy back on track, we first need to manage the virus, because having the virus under control is what will enable small businesses, restaurants, all of those businesses we rely on to really connect with one another to make up our communities, need that first. I'm reminded of the joke. Even if you don't believe in gravity, if you jump out the window, gravity is going to win every time. So don't be a science denier.
Okay, thank you. Yeah, I think we are now reaching the end of our sessions, and I think we have a interesting and important discussion, and we have some note here, and then we have talked about anything. I mean, from America, and also from Malaysia, and also from Singapore, and also we have talked about the vaccination programs and how to talk with our leader about how to prevent COVID. And thank you once again to the panelists for sharing your experience, and to all of the attendees for joining this session. Thank you very much.
Thank you.
Okay, thank you. And then I think for know that the next session, it will be 11 p.m. Jakarta time, and about the topic of managing the relationship between university and teaching hospital in the COVID-19 era. I hope that the participant will still join us in the next 30 minutes. Thank you very much.